Hi, I'm Diane McGarry with Drake Arts.
And I'm Tom McGarry, also with Drake Arts.
In her book, The Body Papers, our January author, Grace Tolosian, speaks about her breast cancer. Because this is such an important issue, we've asked Dr. Sabine Manoli of St. Joseph's Surgical Associates in Nashua, who has had both personal and professional experience with breast cancer, to speak with us about breast cancer concerns. Dr. Manoli, what's the most important thing you can do to help prevent breast cancer?
Well, Diane, you can't prevent it, but you can certainly detect it early. And one of the best things I would suggest to women is getting familiar with their own body. Breast self-exam. I know a lot of patients come and see me and they tell me, I don't check my breasts, they're lumpy, bumpy, I don't know what I'm feeling for. And I'm afraid that if I check them, I'm going to find something and think that it's a cancer. And I usually tell them the best thing to do is to check yourself once a month, because if something changes, you're going to be the first person to know about that. The doctors check you once a year when you come in and, at your GYN visit or at your primary care visit, but certainly they don't live with your body every other day of the year. And so when you check yourself, it's important just to be familiar with what lumps and bumps are normal for your body. And obviously, if there's a new lump somewhere, I usually tell people don't raise the alarms immediately. Keep an eye on it, keep your mind on it, and check it again in a week or two and see if that lump is still there. Very often breasts, as you are going through the menstrual cycle every month, they change, and you can get cysts that pop up when you're in a certain phase of the hormone cycle, and then as your hormones kind of tamper down, the cysts will go away. So if you find something that's new for you, again, keep it in your mind, keep a hand on it, check it again in a week or two, check it in a month or two. If it persists or gets bigger, then that's the time to go see your doctor. And it doesn't matter what age you are. I mean, we often think of breast cancer that it's something we see later in life, and that is true. As we get older, we see it a lot more often than when we are younger. But I have seen patients in their 20s and 30s, as well as in their 40s, with breast cancer that they detected on their own. A lump they found on self-exam. And if you aren't comfortable doing your own self-exam, you can have your partner do your exam. I have had women patients come in where their husband or their boyfriend found a lump and told them to get it checked out. And certainly it doesn't matter who finds it, it just matters that someone finds it. And again, as I said, you can't prevent breast cancer, but you want to find it early. And that's the most important thing, is just being familiar with yourself. Go ahead, I'm sorry.
No, that's all right. Can you talk about how to do a breast self-exam?
I was just going to say, I see that you're scrolling through some pictures on the screen, and the most important thing is to do it the same way every time. So if you like to do it in the shower, that's fine. You want to raise your arm overhead and place it behind your head. What that does is basically stretches out the breast tissue so that it's a little bit more stretched over your pectoral muscles, your chest muscles. And then you use your other hand in a circular motion, moving from the central part of the breast all the way around in concentric circles. You never want to lift your hand off the tissue. You want to continue to move your fingers just kind of in a, shove them forward, if you will, because if you lift up and try to go back and touch the next spot over, you might miss the intervening tissue and miss a little something that's in that intervening portion of your breast.
Oh, wow, I had no idea.
You want to continuously kind of push your fingers forward in a round motion until you've covered the entire circle of the breast to the outside part. And then you always want to check under your arm as well, which is where the lymph nodes reside that typically are associated with the breast and the breast cancer, if you have one. You would then, after you've done one side, you would switch to the other side and use the other hand and do the same thing on that side. The reason the shower is good is because your fingers are wet, It kind of gives you a little less friction so you can move through the motions smoothly. Some people like to do the exam lying down. Again, you want to put your arm behind your head, which stretches out your breast tissue and allows you to feel through the tissue better. If there's a lump, it's going to become more prominent as the breast tissue flattens out over the chest muscle. And that's the same principle that mammograms utilize. They squish the breast tissue between two plates, allowing a density or a mass to kind of compress the surrounds. The mass, of course, doesn't compress between the plates the way the surrounding tissue would.
No.
So you're more able to detect something that way.
That's great information. Now, after that, it's also important to get mammograms, right? I know the age, the age at which we want to have mammograms done keeps on changing.
This is true. True. Yes, mammograms are along with self-exam of the breasts, mammograms are your next best defense. Many women will do exclusively mammograms because they're not comfortable with the self-exams. So in those cases, obviously, the mammograms are the only form of detection. The standard recommendation that I put forward, and that's also mirrored by a lot of our organizations, is mammography should begin at the age of 40 in a woman who has standard risk. The standard risk of breast cancer is 1 in 8 women, so about a 12.5% lifetime risk of developing breast cancer. Now, in women who have a family history or who have a known genetic predisposition towards breast cancer, they should start actually getting breast imaging much earlier. If you are a BRCA gene mutation carrier, you should start getting breast imaging at 25. And typically, because in young women, the breast tissue, it has a lot of hormone responsiveness, they're still having menstrual cycles, the tissue tends to be quite dense in young women. We actually say for those genetic mutation carriers to start breast screening with MRIs between the ages of 25 to 30. And then, again, this is for the high-risk women,
Sure.
Then beginning with mammograms and MRIs from 30 onwards. But your standard, 12.5% lifetime risk person, female, we say standardly mammography should begin at the age of 40 and should be yearly. There are some organizations out there. The U.S. Preventative Task Force put out some recommendations a few years back that said it was perfectly safe to start mammography at the age of 50 and to do them once every 2 years. And that's completely against everything that I believe in the fiber of my being. I've had a number of patients, myself included, who were diagnosed with breast cancer in their 40s. And if it had not been for getting a mammogram before the age of 50, well before the age of 50, myself and those patients would not have had their breast cancers identified. So I think sometimes a lot of these organizations their recommendations aren't necessarily based on the best interests of our patients, but rather on saving money for insurance companies, which is a whole nother topic we don't want to get into.
I don't want to go there.
Kind of an ugly topic, but I think, they look at more how much does it cost to do mammography for all these women between the ages of 40 and 50. Yes, the majority of breast cancers are found after the age of 50. However, for those women who are under 50 who have a breast cancer, they do much worse if their cancer is not found early. And that's because they're still having menses and they're still having hormone cycles that fuel these cancers to grow. So your population of women under 50 who have breast cancer have much worse prognosis if the cancer is not found early. And that's not so much the case postmenopausally. But again, the U.S. Preventative Task Force is looking at, well, how many mammograms do we have to pay for to find one cancer under the age of 50? And that's how they make their recommendations. But standard recommendation, 40 and above, yearly mammogram. And if you're high risk, we start sooner. And to know if you're high risk or not is a conversation with your physician, looking at family history and a number of different factors.
Sure. And I think I want to point out, I'm 66 now. That recommendation of when to get your mammogram has changed over time. So people, and how often. It used to be every year, then it was every 3 years. So I think people have to stay informed and up to date and have to continually be aware that there is a risk for this disease. And my aunt got it in her 80s, and my niece got it in her 20s. So there's a wide age span there of women, and just being aware of that and knowing it's 1 out of 8 women gets breast cancer, right?
In their
That's
lifetime,
not,
yeah.
you know, I
It's
mean,
not insignificant. No, I mean, if
no.
you think about a room full of your friends, sisters, and coworkers, and you've got at least 1 or 2 in that room right there
Right.
that will be affected at some point in their life.
So before we move on from mammograms, because this is such an important thing, I want to point out that there are a lot of people who don't have insurance, even though we're working towards that in this country, and I don't want to get into that political issue. But the
Right.
National Breast Cancer Foundation has a page where it says find a facility, and you can go on here, and it's by state. They're listed all here. Now the problem is that I want to point out to people this isn't always up to date. The one in Massachusetts is not currently seeing people. But you can go to the Massachusetts League of Community Health Centers and ask. Those are for people outside the greater Boston area. For those inside the greater Boston area, there is something called the Women's Health Network. This is information I got from Anita Christie, who's a nurse she's the director of the Division of Clinical Preventive Services at the Massachusetts Department of Public Health. And if you need help and you can't find a facility, please talk to her. Don't hesitate to call Boston. That's what they're there for. And they're not just dealing with COVID, they're dealing with all of our health issues and problems. And it's really important to get that information if you don't have it at your fingertips.
Diana, I think you forgot to point out that these are programs that will screen breast and also for cervical cancer for women who are uninsured or underinsured.
Yes.
These are free programs. So you can, if you're over 40 and you need a mammogram or a pap smear, these can be obtained for free if you can't afford to do so.
Well, interestingly, I now have the New Hampshire website up, and this program is being taped in October, but it won't be shown until after that. So please, I know it's National Breast Cancer Month while we're taping it, but breast cancer is always an important thing. This New Hampshire Department of Health and Human Services, it actually says in the information here that the Let No Woman Be Overlooked program does free breast and cervical cancer screenings for women 21 to 64. I think.
Well, after that, you reach Medicare age where that's covered by Medicare.
Right, but it starts at 21, which is really important. Don't think you're not the right age. And under that, I believe there's special programs for children because that's what you would be considered as a minor. And it's very important. You can get a health exam, a mammogram, a pap test, and a pelvic exam. These are, it's so important to take care of your own health. No one else is going to take care of it if you don't take care of it yourself.
Absolutely.
So you mentioned we've done breast exams, we've done mammograms, and you mentioned in there genetic testing. What is that all about?
Well, so, obviously the author that you're featuring for your January Drake at Arts, she had genetic testing. She also had a known mutation found in her family.
Right.
And, what you see in the book is exactly what typically happens is that one family member gets diagnosed with breast or ovarian cancer, which then triggers the remaining family members to say, wait a minute, she's awfully young. There's something going on here. Her doctor suggests that she gets tested, and then other family members subsequently follow suit. So genetic testing is not for everyone. It does tell us if there's a family where we see a lot of first-degree relatives that have similar cancers or that present with these cancers at a young age, that something might be going on genetically, and that's why we start testing family members who are unaffected, like Grace in the book was unaffected, but she did have a genetic mutation, which subsequently led to her making some choices. So we look for families where there's an awful lot of young cancer presentations. In the book in particular, they highlight BRCA1 and 2 mutations, and that's, I believe that family that Grace, the author, is a part of, it's a BRCA1 mutation that she tests positive for. So when you go to your doctor, they typically will take a family history. So when you have a primary care visit, they ask you, does anything run in your family? And the reason we ask that is because we're looking for red flags like your mom had ovarian cancer or your mom had breast cancer and she was only 35 when she did. So that would be a giant red flag. Or your sister had this, or your father had breast cancer. So male breast cancer, very commonly associated with a genetic mutation.
Really?
It is, yeah. And most male breast cancers are related to genetic mutations, whereas actually most female breast cancers are not. So there's a lot of media attention directed towards genetic mutations that drive potential breast and ovarian cancers. And yet the majority of breast cancers are not things that run in families. They're not related to genetic mutations. However, the family members, the patients who do have genetic mutations tend to present with their cancers at a younger age. So when we see breast cancers in somebody under 50, and certainly under 40, that's a red flag that requires genetic testing of that individual. And then subsequently, if they're found to have a mutation, we would then offer testing to their family members. If we see ovarian cancer in any of your first degree relatives, that's usually an indicator to look for a BRCA1 or 2 mutation.
What's a first degree relative?
So that would be your mom, your sister, whereas a second degree relative would be an aunt or a cousin. And, there's another misconception that's out there that breast cancer only passes from the maternal side. That is not true. So 50% of a person's genetics come from their father and 50% from their mother. So if your paternal, your father's side has a whole lot of cancers, you're just as much susceptible because that gene could be passed from the paternal relatives right on to you through your father. In fact, that's what happened to me. But, I think there was a misconception years ago where we would only ask in terms of breast and ovarian cancer about somebody's mother, their maternal side. And that's completely wrong. It can come from the father. And in fact, the book, the author, Grace, there, it did come from her father's side, the deleterious gene. So, again, an example, case in point, that, what I'm saying is correct. And it's important to not just look at the maternal side. But first degree relatives would be your immediate family. So your parents and your brothers and sisters. And then second degree relatives would be cousins, aunts, uncles, grandparents. And then, of course, there's third degree relatives, anybody beyond that point. You could keep going. But if you find it in the first degree relatives, that's much more linked to your genetics, much more closely linked to your genetics. And then second degree also can be, but a little bit farther removed, obviously, and then, on and on from there. If you have an affected family member, like, for example, your mom had breast cancer at 35, well, she's 70 now, and obviously in her day, she didn't test for it. What we advise is actually that the affected family member be tested first, if your mom is still living, that she be tested for a genetic mutation, because if she's found to have one, then first of all, your testing is usually covered. The genetic testing companies will cover free of charge, the testing for other family members, but then also you're much more likely to have a mutation in that case if your mom or your dad is found to have one. So it makes more sense to test. Now, if your relative who is affected is no longer living and you're worried, and you go and have an appointment with a genetic counselor and you look at your family history and your family tree, they may advise you to test anyway, even though those other family members are no longer testable. And that's okay if they're not living clearly, or if sometimes family members who are living don't want to have the test. They say, I don't want to know, or I don't want to do this. And that's okay. You can still test as an individual. The most important thing for genetic testing is going to the visit with your family tree, your family history, as much of it that you can obtain before the visit. Having that information is very helpful to the genetic counselor. And the visit is just, you sit down, you talk through your family history, you talk through your concerns, your own personal concerns. And at the end of the visit, the genetic counselor will say, you're, based on what we've discussed, your risk percentage-wise of having a genetic mutation is X. So if the genetic counselor says, well, your risk is about 50% that you might have one, you may be more inclined to test because you'll say, boy, I really want to know. Or you may run away screaming and say, I don't want to know.
People don't want to do the test because I'm thinking, I'm not sure I would want to do the test.
Right, and that's fair. I mean, I think, I typically advise patients who fall into a high-risk category, at least speak to the genetic counselor about your risk. They can give you a good guesstimate percentage-wise of what your risk might be. That's without a test. It's just based on your family history. And then at the end of those visits, it's your choice to test or not. And the test is just a blood draw. So it's not, a huge painful thing that you have to go through. It's not that invasive. And it really is a decision because, as you pointed out, you may not want to know. There are ramifications. There's consequences of knowing. Young women who are, let's say they have an affected family member and they go through the gamut and go through the testing. It's a lot to handle, to know that, let's say you're 25 or 30 years old, you haven't had children yet, you find out that you have a BRCA mutation and you're now at a very increased risk for breast and ovarian cancer. And, a lot of people will counsel BRCA carriers to get their ovaries out by between 35 and 40 or after they've finished childbearing. And if you're 35 and you haven't met the person you want to have children with, and you feel this sort of pressure to take your ovaries out before you get ovarian cancer, it gets really scary and stressful.
Oh, yeah.
So,
these are really hard decisions you're talking about.
They're very hard decisions. And by the same token, the BRCA carriers are also counseled about their breast health. There's a couple of choices. I mean, number one, you can opt to have a double mastectomy, which would be your best risk reduction strategy in terms of, it reduces your risk of developing breast cancer down as low as it can. Not to zero, because no matter who does your mastectomy, it's never completely removing every single cell of breast cells that you have, but it gets it down, as close to 100% cure as you can, or 100% prevention as you can. Alternatively, a lot of people don't want to have their breasts removed, and I have a lot of patients who are known genetic carriers for breast cancer risk, and they choose instead to do what we call high-risk surveillance. So we get them into a very dedicated timeline of checking on them quite frequently. We check on them quarterly. Every 3 months, they have something done. The two biggest things are mammography and breast MRI. And those are done once a year. Each of them are staggered by 6 months. So, for example, you'd have an MRI every December and a mammogram every June. And then,
is that the same follow-up for people who've had breast cancer? Because one of my friends, she goes and has those types of tests at least annually.
It depends. So there are definitely some of my breast cancer survivors that we will continue to use that intensive surveillance, and there's a number of different reasons. The other thing that we do with people who want to keep their breasts but are a known high-risk individual because of a genetic mutation, in addition to those tests, we also intersperse physician breast exams. So again, if you take the December and June timeline for mammogram and MRI, you would do in March, and in September you would do a physician breast exam. Sure. And then every month in between all of that, the patient's doing breast self-exam, and we really counsel them what they're looking for and how to do it. So they're getting quite a bit of surveillance. The idea, again, is not prevention. We can't prevent a breast cancer, but we would detect it early on in the course, where the treatment options are much more vast. When you wait and you kind of don't have surveillance, things present much more late in the course, and then the treatment options go down as far as what you can and can't do at that point. So,
what are the treatment options for breast cancer?
Again, a big topic that is hard to kind of boil down into a quick synopsis, but primarily, and mind you, I'm a surgeon, so I'm going to tell you that surgery is the best and end all be all, but it's not always the case. But, if we think about a garden variety breast cancer that's detected on a mammogram, or a lump that's detected by the patient, and then she comes in and has imaging to confirm it, and subsequently a biopsy, which is usually done, it's called a percutaneous biopsy, through the skin with a little needle, to take a portion of the cells of the lump, whether the lump be something she feels or whether the lump be detected on imaging. Once the biopsy comes back confirmatory at that point, if it's an early stage sort of garden variety tumor that presented in this manner, we would discuss surgery and the surgical options. If it's small and the patient has a reasonably sized breast that we can maintain the majority of the breast, we would do a lumpectomy, which means a portion of the breast is removed, obviously the portion containing the cancer, but the remaining breast tissue would be left behind. And most women are interested in preserving their breast tissue if possible. It's, cosmetically, obviously still looks like they do before we start. And just for the sake of, I think women really, as much as maybe we don't want it to be a symbol of our femininity, it ends up being that way. We're sort of culturally trained to view it that way. It's hard to detach oneself from a breast. It's crazy to say this, but it's almost easier for somebody to accept a limb amputation rather than a breast amputation. And it's crazy, but it's just the way society has conditioned women to believe that, you have to have your breasts to be a woman, and that's not at all true. But I think we see a breast in a woman, we see them in clothing, and we expect that when they're female. And if it's not there, we don't really know how to rectify that with our visual and our minds. But anyhow, yes. So, mastectomy is something that is preserved for either a very advanced cancer where it's quite large and there's not a lot of breast tissue remaining that's normal around the tumor, or a woman that has a small breast and a larger tumor. Again, there's a bit of a balance between how much you can save and how much they have left after you've taken the tumor out. And you can't just remove the tumor and leave 10% of a person's breast. Cosmetically, that would not look good. And there is a bit of a cosmetic component that you have to consider in their surgical approach. Subsequent to surgery, if somebody has had breast preservation or breast conservation, meaning they've had only a portion of their breast removed, at that point, they may be a candidate for radiation, which is usually needed in women who are under 70 with a smaller tumor and a lumpectomy. They usually have radiation following their recovery from surgery. Occasionally, they'll have chemotherapy depending on how aggressive the cancer is. And these days, stage of the cancer doesn't always determine the need for chemotherapy. It's another misconception, I think, that's been out there, and that's changed. I mean, things with breast cancer are constantly changing, and that's one of those things that has recently changed. There's a whole lot of other factors that we use to decide if somebody's breast cancer requires chemotherapy. So even a stage 1, which is an early stage, stages go from 0 to 4. Stage 1 is a very early stage. Still, there are patients with stage 1 cancers that have no spread anywhere, but it's an aggressive type of cancer, and they'll be recommended to receive chemotherapy. So those are the mainstays of treatment: the surgery, the radiation, the chemotherapy. And then there are some hormonal adjuncts that we use. Those are pills that we prescribe to patients to take on a daily basis that are risk reducers. They reduce the risk of breast cancer developing in the remaining breast tissue. So if the woman has preservation of the affected breast plus her other breast, the hormonal adjuncts really help to reduce the risk of a recurrent cancer. If women don't have breast tissue remaining, those hormonal adjuncts are less necessary, obviously, as would be radiation.
So I do want to talk to you a little bit, just a smidgen, about breast reconstruction, but also, since we have my husband here, I think it's important to point out how much support is needed for going through any type of surgery, but this one in particular, because as you mentioned, women's self-esteem is so much in different parts of their body, and especially with being able to bear children or be able to breastfeed or just having breasts, and how important a partner can be in going through something like this.
Right. It absolutely is. I mean, I meet a lot of women at the beginning of their journey, and I see them through the end of it. And, it's when they come in with a life partner, a best friend, a sister, somebody who is their right-hand person, they go through their journey so much more easily and so much better than those who come in alone.